Assalamualaikum doctors. I am going to talk about today on antepartum hemorrhage, which is represented by APH. So actually antepartum hemorrhage, it is a self-explanatory term. By looking upon anti, it stands for before, partum represent the time duration like delivery, while hemorrhage is more associated with bleeding, like bleeding before delivery. But how you will properly define antepartum hemorrhage? So simply we can say it is the bleeding from vaginal tract after 24 weeks of pregnancy and before birth of baby. That's it. So it's so simple. Let me write the definition. What is the definition of antepartum hemorrhage? It is the bleeding from vaginal tract after 24 weeks of pregnancy and before birth of baby. So what is antepartum hemorrhage? It is the bleeding from vaginal tract after 24 weeks of pregnancy and before birth of baby. And this is how you differentiate the antepartum hemorrhage from abortion. And abortion also, there is a bleeding from vagina, but that is before 24 weeks of pregnancy. So it is important. Now what is the incidence rate of antepartum hemorrhage? So usually antepartum hemorrhage, it complicates 3 to 5% of total pregnancies. So antepartum hemorrhage, it complicates 3 to 5% of total pregnancy, and it is also considered as one of the leading cause of perinatal and maternal mortality worldwide. Now coming toward the major causes of antepartum hemorrhage. So the causes of antepartum hemorrhage, it is divided into 3 categories. That is, the first major cause is, that is placental bleeding. And there is extraplacental bleedings, and unexplained causes. There are certain unexplained causes. So what is the most common cause for the antepartum hemorrhage? That is the placental bleeding. So usually placental bleeding, it comprises of 70%, while extraplacental bleeding, it comprises of 5%, while unexplained causes, it comprises of 25%. So the placental bleeding, it is the most common cause for antepartum hemorrhage. Now the placental bleeding, it is divided into 2 categories further. That is, the first type is, that is called as placenta previa, and the another is abruptio placenta. Now actually the placenta previa and abruptio placenta, it constitutes same, like it constitutes 35%, also it constitutes 35%. Now what is placenta previa and what is abruptio placenta? Now in placenta previa, there is an implantation of placenta and lower uterine segment. Simply, what is placenta previa? Here there is an implantation of placenta and lower uterine segment. Like, let's suppose if this is uterus, so if this is an imaginary line, so it will divide the upper uterine segment and it is a lower uterine segment. So it is a upper uterine segment, this is lower uterine segment. So normally the placenta get implanted into the upper uterine segment. But in a condition of placenta previa, here the implantation of placenta occur in the lower uterine segment rather than upper uterine segment. So in placenta previa, the implantation of placenta occur and lower uterine segment. This is how we call it as a placenta previa. And abruptive placenta, however, the implantation of placenta is normally like it is the implantation of placenta will be an upper uterine segment, but there is a premature separation of placenta from the uterus. Here the implantation of placenta is an upper uterine segment, but there is premature separation of placenta from uterus. So I repeat, in placenta previa, the implantation of placenta is in lower uterine segment, and abruptive placenta, the implantation of placenta in upper uterine segment normally, but there is premature separation of placenta from the uterus. We will be discussing each part in detail. Now the another causes are extraplacental bleeding. These extraplacental bleeding, it is due to the cervico-vaginal lesions, like if there is cervical polyps, if there is cervical carcinoma, if there is cervical polyps, cervical carcinoma, if there are varicose veins, so it could lead to the antepartum hemorrhage, while there are certain unexplained causes as well. Now the causes of antepartum hemorrhage are placental bleeding, extraplacental bleeding, and unexplained causes. And placental bleeding, there are placenta previa and abruptive placenta. Now we will be discussing each type of placental bleeding, that is placenta previa and abruptive placenta. Now let's talk about the placenta previa. So what is placenta previa? So as you know that placenta is a structure which provides oxygen and nutrients to the baby, and also it removes the waste product from the baby blood. While previa is divided into two categories, it is divided into two terms, that is pre, which means before, and via means way. So let's talk about the first type, that is a placenta previa. So placenta is a structure which provides oxygen and nutrients to the baby, and also it removes the waste product from the baby blood. While previa, the pre stands for before and via means way. But how, simply if we say what is placenta previa, it is simply, we can define it that it is the implantation of placenta into the lower uterine segment rather than upper uterine segment. So normally if there is implantation occur of placenta, so it occur in upper uterine segment, but in condition of placenta previa, here the implantation of placenta occur in lower uterine segment. Let's suppose this is a uterus, and this is a upper uterine segment, this is a lower uterine segment. So if there is normal condition, so what happens in normal condition, the placenta will be implanted into the upper uterine segment. But in case of placenta previa, the implantation of placenta occur into the lower uterine segment. So this is how we will be dealing in placenta previa. So in placenta previa, actually during pregnancy, the lower uterine segment get dilated, as it is a poorly vascularized area, so there will be inadequate uteroplacental perfusion, which drastically affect the neonatal outcome as well. So now let's talk about what are the major causes of placenta previa. What are the major causes of placenta previa? So the exact cause of placenta previa is unknown. The exact cause of placenta previa is unknown. But yet there are certain theories which put forward in order to explain the possible reason for the placenta previa. So there are certain theories. The first theory is that is called as dropping down of zygote theory. Now, the first cause is that is called as dropping down of zygote theory. Now, as you know that the fertilized ovum after 72 hours, it get transferred from the fallopian tube and to the uterus. During the time of this transferring, if these fertilized ovum, it get fall and get implanted into the any side other than upper uterine segment, like if it get implanted into the lower uterine segment, so this could lead to the placenta previa. So, and dropping down of zygote theory, here it suggested that during this transferring of fertilized ovum, if it get implanted into the lower uterine segment, so it could lead to the placenta previa. And why it is so? Why it get fall into the lower uterine segment? Because of poor decidual reaction. So, and dropping down of zygote theory after the fertilized ovum after 72 hours, it transferred from fallopian tube and to the uterus. So, if it get implanted in lower uterine segment, if it get implanted into the lower uterine segment, so it could lead to the placenta previa. And why it is so? Due to the poor decidual reaction. Now, what is actually decidua? So, actually decidua is the innermost lining of the uterus. Or by another hand, we can say that endometrium in pregnancy, it is called as decidua. So simple. So if there is any changes occur in endometrium, so this is called as a decidual reaction. So because of poor decidual reaction, the transferring of fertilized ovum from fallopian tube, it could occur into the lower uterine segment, which could lead to the placenta previa. The another cause is, the first cause is dropping down of zygote theory. The another is persistence of chorionic activity and decidua capsularis. So usually the chorionic activity, it is more active in the decidua basilis layer of the endometrium. But if for any reason, if these chorionic activity occur at any site other than decidua basilis, so it could lead to the placenta previa. So normally the chorionic activity, it is more prone in the decidua basilis, but as decidua capsularis, it is from the decidua basilis. So if there is activity, if there is chorionic activity in decidua capsularis, so it could lead to the placenta previa. And also if there is defective decidua, like date of spread of villi and to the another sites, and also multiple pregnancies. So multiple pregnancies, and multiple pregnancy, the placental bed become enlarged and it could implant into the lower uterine segment. So it could lead to placenta previa as well. So these are all, there are certain causes of placenta previa. The major causes are dropping down of zygote theory, the persistence of chorionic activity and decidua capsularis, defective decidua, and multiple pregnancies. Now, what are the major predisposing factors which could lead to placenta previa? Now, what are the predisposing factors for placenta previa? The predisposing factors are, the first one is, that is a cigarette smoking, cocaine use. So if a patient take cigarette smoking and if a patient take cocaine, so in that condition could lead to placenta previa. Also, if there is old age in female, like if there is more than 35-year age in the female, and if there is C-section had done in the past history, and if there is dilation and curettage occur. So what are the major predisposing factors for the placenta previa? That is cigarette smoking, cocaine use, old age in the female like more than 35 years, and if there is a C-section in the past, surgical history, and if there is dilation and curettage occurred to the female. So these are major predisposing factors for placenta previa. Now let's coming toward the types of placenta previa, which is very important. Now what are the types of placenta previa? So there are 4 types of placenta previa. What are those 4 types of placenta previa? That are, now what are the types of placenta previa? It is also called as degree of placenta previa. It is also referred as a Brown classification. Brown's classification. Now, placenta previa, it is divided into 4 groups. The first group is that is called as type 1 placenta previa. The another type is type 2 placenta previa. Type 2 placenta previa. There is type 3 placenta previa, and there is type 4 placenta previa. So what are the types of placenta previa? The first type is type 1 placenta previa, which is also called as a low-lying placenta previa. It is also called as a lateral placenta previa. Lateral placenta previa. The type 2 placenta previa, it is also called as marginal. It is also called as marginal placenta previa. Type 3 placenta previa, it is also called as incomplete or partial placenta previa, and type 4 placenta previa is called complete placenta previa. So we will be discussing each type in detail. Now the type 1 placenta previa is also called low-lying placenta previa. It is also called lateral placenta previa. Now normally what happens? Let's suppose this is a uterus. So let's suppose this is a uterus. This is a imaginary line which divides the upper uterine segment. Let's suppose this is the upper uterine segment. This is a lower uterine segment. Now normally the implantation of placenta occur in upper uterine segment. Normally the implantation of placenta occur in upper uterine segment. Now what happens in type 1 placenta previa? In type 1 placenta previa, the major portion of placenta, it is lying in upper uterine segment, but a smaller portion of placenta previa, it is lying in a lower uterine segment. So in type 1 placenta previa, let's suppose the placenta will be as, look like as this. So it will indicate us that the major portion of placenta, it is lying in a upper uterine segment, while the smaller portion, it is lying in lower uterine segment. So in type 1 placenta previa, the major portion of placenta is lying in upper uterine segment, while minor portion is lying in lower uterine segment. So this is type 1 placenta previa. Now as in type 1 placenta previa, it do not involve the internal os. Internal os means internal orifice. Internal orifice, it is the junction between the uterine cavity and the cervix, while external os is a junction between the cervix and vagina. So here it do not involve the internal os, so it means that the normal vaginal delivery is possible here. So it do not involve internal os. That's the reason that the normal vaginal delivery is possible. Now coming toward the second type of placenta previa, that is called as type 2 placenta previa, which is also called as marginal placenta previa. Now in type 2 placenta previa, the major portion of placenta is lying in lower uterine segment, while the minor portion of placenta it is lying in upper uterine segment. So here in type 2 placenta previa, the major portion will be lying in lower uterine segment, while minor portion is lying in upper uterine segment. So here the type in marginal placenta previa, the major portion of placenta is lying in lower uterine segment, while the smaller portion lying in upper uterine segment. Now the type 2 placenta previa or marginal placenta previa, it is divided into two groups further, that is called as a type 2 anterior placenta previa and type 2 posterior placenta previa. So I repeat, the type 2 placenta previa is divided into two groups, that is type 2 anterior placenta previa and type 2 posterior placenta previa. It means in type 2 anterior placenta previa, here the implantation of placenta occur, here the implantation of placenta occur towards the pubic symphysis. While in type 2 placenta previa, here there is implantation of placenta towards the sacral promontory. So let's suppose if this is a uterus, so let's suppose if this is a belly of the female and this is the back of female. So in type 2 anterior placenta previa, the implantation of placenta is toward the pubic symphysis. So let's suppose if this is a pubic symphysis, so the implantation of placenta will be like toward the pubic symphysis. While in type 2 placenta previa, the implantation of placenta is toward the sacral promontory. So if there will be sacral promontory, so the implantation will be like in this manner. It will be toward the sacral promontory, while in anterior placenta previa, it will toward the pubic symphysis. So coming toward the type 3 placenta previa, which is also called incomplete placenta previa. So here the major portion or we can say the most of the portion of placenta, it will cover the lower uterine segment, but along with that it will cover the internal os as well, but not completely. So here in incomplete placenta previa, there is the major portion of placenta is lying in lower uterine segment, along with that it cover internal os partially. So let's suppose if this is a internal, so here there will be, let's suppose this is a placenta. So the most portion of the placenta is lying in lower uterine segment, along with that it cover the internal os partially. So it will not cover the internal os completely. Here the internal os, it will cover the internal os partially, and that's the reason that the normal vaginal delivery is possible here. The normal vaginal delivery is possible here, but still there is high risk. So that's the reason that we usually recommend the C-section. C-section is usually recommended here. Usually recommended. Now, while talking about type 4 placenta previa, here the placenta completely cover the internal os. Here the placenta cover the internal os completely, so there will be no vaginal delivery. So the normal vaginal delivery is not possible. and usually here we recommended the C-section. So C-section is recommended. So I repeat, what are the types of placenta previa? Type 1, type 2, type 3 and type 4. Type 1 placenta previa and type 2 anterior placenta previa, it is considered as a mild placenta previa, while type 2 posterior placenta previa, type 3 placenta previa, type 4 placenta previa, it is considered as a major placenta previa. So, and type 1 placenta previa, the major portion of placenta cover the upper uterine segment, while small portion cover the lower uterine segment. While the type 2 placenta previa, the major portion of placenta cover the lower uterine segment, while the smaller portion it cover the upper uterine segment. So if there is type 2 anterior placenta previa, it will cover the lower uterine segment toward the pubic symphysis, while if there is type 2 posterior placenta previa, so the major portion of placenta will be lying in lower uterine segment and it will toward the sacral promontory, while in type 3 placenta previa, the most portion is lying in lower uterine segment, along with that it will cover the internal os partially, while type 4 placenta previa, the placenta will cover the internal os completely, which is more serious condition. So student, this is all about the placenta previa types. So now let's talk about the sign and symptoms of placenta previa. So if a patient is suffering from placenta previa, so what will be the presentation of those patients? So now let's talk about the sign and symptoms of placenta previa. So let's talk about the sign and symptoms of placenta previa. Sign and symptoms of placenta previa. So what is the main symptom of the patient? So that is vaginal bleeding. Now the vaginal bleeding, what are the characteristics of vaginal bleeding? That is painless, recurrent and causeless. So the painless is due to absence of uterine contraction. Recurrent means that sometimes the vaginal bleeding is start and sometimes it gets stopped, and causeless as well. So the vaginal bleeding will be like painless, recurrent and causeless. Now this vaginal bleeding, it is often bright red in color. It is bright red in color, and initially vaginal bleeding is scanty and later it profuse. So the main symptom is that there will be vaginal bleeding. It is painless, recurrent, causeless. The vaginal bleeding is often bright red in color. Initially it is scanty and later it becomes profuse. Now what are the signs of the patient with a placenta previa? So if there is severe blood loss, so there will be anemia and fetal, there will be floating fetal head and fetal heart sounds can be heard, and there will be stellworthy sign. So the symptoms are vaginal bleeding, and vaginal bleeding is often bright red in color. It is initially scanty, later profuse. What are the main signs of the patient? If there is severe blood loss, so usually the patient is presented with anemia. There will be floating fetal head. The fetal heart sound could be here, and the stellworthy sign is positive. Now, what are the diagnoses of placenta previa? So for the diagnosis, you have to collect the proper history. There will be history collection, and then do physical examinations. So, and physical examination, you can go for abdominal examination. Also, you have to go for vulva inspection in order to visualize the bleeding. But remember that the per-vaginal examination is contraindicated. Per-vaginal examination is contraindicated. And why it is so? The reason is that it could lead to the massive bleeding. So you have to collect the proper history. You have to do for physical examination. You can go for abdominal examination, vulva inspection. But remember that the per-vaginal examination is contraindicated as it is because it could lead to the massive bleeding. And you can go for placentography as well. Placentography in order to confirm the placenta previa. So there is placentography. Also, you can go for the double strip examination. And transvaginal sonography. And it is considered as a gold standard for placenta previa. So how will you diagnose the patient? You have to collect proper history. You can go for physical examination. For the confirmation, you can go for placentography. You can go for double strip examination, while the gold standard is transvaginal sonography. So this is all what we need to know about the sign and symptoms plus the diagnosis of placenta previa. Now let's talk about the management plan for the patients of the placenta previa. Now let me tell you what is the goal of pregnancy. The goal of pregnancy is healthy mother and healthy fetus, and we are trying our level best that the baby should reach to the 37 week, like the baby should reach to the term. The term is 37 week is equal to term, while if the baby is less than 37 weeks, that is called as preterm, and if it is more than 37 weeks, so this is called as postterm. Now let's talk about the management plan for placenta previa. Now placenta previa patient if presented with you, and if there is massive bleeding, if there is heavy bleeding, and it is difficult to control with medication, and another hand, if there is minimal bleeding and control with medication. So if the patient of placenta previa presented to you, if there is a heavy bleeding and if the condition is not treating with medication, so in that condition you have to terminate the pregnancy. Now, while on the other hand, if there is minimal bleeding and if the condition is treated with medication, so in that condition you can check whether it is a preterm or postterm. So if there is postterm conditions like more than 37 weeks, or if there is less than preterm condition less than 37 weeks. So even though if there is minimal bleeding and the condition, even it is treated with medication, but if the condition is postterm, so still we have to terminate the pregnancy because we are not want to delay the pregnancy further. But if there is condition less than 37 weeks, so in that condition we can go for expectant management. Till 37 weeks, and this expectant management, it is called as a Mucoff regimen. So let's talk about the expectant management. Expectant management. So the goal is to carry pregnancy till the 37 week. Now expectant management, for the expectant management there are criteria. So what are those criteria? So the first criteria is there should be no active bleeding. There should be no active bleeding. The patient is hemodynamically stable. The gestation age should be less than 37 weeks. The CTG should be reactive, means the fetus is in good status, and there is no fetal anomaly. So what are the criteria for the expectant management? There should no active bleeding. The patient is hemodynamically stable. The gestation age is less than 37 weeks. CTG is reactive, and there is no fetal anomaly. Now, what we do in expectant management? So initially we have to hospitalize the patient and also advise for the bed rest. And if there is anemia and shock, so you can go for blood transfusion as well, and you can give steroids for lung maturations as well, and you can go for short-term tocolytics if there is active uterine contraction, and you can go for nifedipine. Now, for the expectant management, initially it is important that we have to hospitalize the patient, and you advise the patient to the complete bed rest, and if there is anemia and shock to the patient, so you can give blood transfusions. For the lung maturation, you can give steroids, and if there is active uterine contraction, so you can go for short-term tocolytics, for example, in the form of nifedipine. So this is all about the expectant management. And for the active management, the second option is for active management. Now, active management, it depends upon the condition and types and degree of placenta previa. As you know that there are 4 types of placenta previa: type 1 placenta previa, type 2 placenta previa, type 3 placenta previa, and type 4 placenta previa. Already we discussed it previously. Now, type 2 placenta previa, it is divided further into 2 groups: type 2A placenta previa and type 2B placenta previa. And already I told you that type 1 placenta previa and type 2A placenta previa, it is called as mild placenta previa, while the type 2B placenta, type 3 and type 4 are considered as a major placenta previa. Now, for the type 1 and type 2A placenta previa, for the type 1 and type 2 placenta previa, like type 1, type 2A and type 2 placenta previa. So for that conditions, we can give oxytocin if there is active uterine contraction, so we can go for oxytocin. But for the type 3 placenta previa and type 4 placenta previa, the normal vaginal delivery is not possible as such. So in that condition, you can go for there is only one option for us, that is a C-section. So you will go for the C-section. So I repeat, if the patient is presented with the condition of placenta previa, if there is a massive bleeding and the condition is not treating with the medication, so you can terminate the pregnancy. While in another hand, if there is a mild bleeding condition is treated with medication, so in that condition you will see whether it is a preterm or postterm. If there is a postterm, so you have to terminate the pregnancy because we don't want to delay the pregnancy further. If there is a preterm condition, so you can go for expectant management till 37 weeks, and that is called as Mucoff regimen. Now, for the expectant management, there are criteria, that is no active bleeding, the patient should be stable, the gestation age should be less than 37 weeks, and the CTG is reactive, and there will be no fetal anomaly. So in that condition, condition, you have to advise a full bed rest to the patients. Also, you will go for blood transfusion if there is anemia or if there is complete shock. And also, you can give steroids for the lung maturation, and you can go for tocolytics if there is active uterine contraction. While for the active management, it depends upon the degree of placenta previa. And for the type 1 and type 2 placenta previa, we can go for oxytocin, while for the type 3 and type 4 placenta previa, there is only one option, that is C-section. So student, that's all about the antepartum hemorrhage first types, that is placenta previa. Hopefully you will like this video, and if you have any query, please put your question in comment section. I'll definitely try to answer. Thank you so much.